Okay, so it's my pleasure to welcome all of you.
Steve, we only have we're going to wait a few minutes. We have about.
Oh, sorry.
That's
okay.
I
thought this was my cue.
Yeah, we're going to wait because we have about 30 participants right now. So I think we should
no problem
wait a couple more minutes. Okay, I don't want to throw us off with timing, Steve. I think people continue to trickle in, so I think we can go.
Okay. The same as when it's live.
Yeah.
All right, so I'm going to go ahead and get started then. I want to give a warm welcome to all of you to the 8th Annual Vermont Center on Behavior and Health Conference. And with this year's topic is rural addiction and health. So as many of you know, our center focuses on the relationship between behavior patterns or lifestyle and risk for chronic disease and premature death. That can sound a little abstract, but when I point out that the behavior patterns we're talking about are substance use disorders, cigarette smoking being the biggest killer, but also the crisis we have now with opioid use disorder, not adhering to medically recommended regimens. So usually we're talking about colonoscopies and regular exercise, but this year we're living through a pandemic where we're having great difficulties getting certain groups to adhere to public health recommendations. So the U.S. population health lags far behind other developed countries. And when that's despite spending by orders of magnitude more on healthcare than any other country in the world. And when population health experts try and understand why that's the case, these behavior patterns or lifestyle appear to be the major contributor. So they are overrepresented among socioeconomically disadvantaged populations and other stigmatized subpopulations and thus an important contributor to the unsettling problem of health disparities that we're all too familiar with these days. But research on the same problem has come to identify rural residents as also a risk factor. These problems are overrepresented in rural settings. It's not independent of the socioeconomic disadvantage, but it's a new insight that we have to better understand, and that's what we're going to try to do during the next 2 days. We feel we have an outstanding program, and I make sure that I don't go too long here, and we allow time for everyone to make their presentations and to have the wonderful conference we're hoping for. But I have some thank yous to make, of course, for this kind of event. So first of all, I want to thank the VCBH administrators, Nicole Tuig, Noelle Savoyan, and Susan Enos. These things take a lot to organize, and if it was on me, I think it would be too much, but they do a tremendous job, and I really sincerely extend my thank yous to them. We also want to acknowledge the generous grant support that we have that makes this possible, from the National Institutes on Health, NIDA, and NIGMS in particular, the Food and Drug Administration, HRSA, and then also the University of Vermont. I want to give a special thank you to Senator Leahy, who individually went out of his way to make sure that we had funding, that is, Vermont had funding to combat the opioid use epidemic, and that came to Vermont in the way of HRSA and a new center we have at the University of Vermont as part of the VCBH on rural addiction, being led by Stacy Sigmund and Sarah Heil. So I think the last thank you I wanted to mention is to all of our speakers who have taken time from their busy schedules to be on this conference call with us for the next 2 days. I wish, as I was mentioning to our keynote speaker before starting here, that we were doing this in our usual way in person at the Burlington Hilton, right next to beautiful Lake Champlain. And let's hope together that that's where we'll be next year. But here we are, and I think we're, as I said, in for a wonderful 2 days of trying to drill down not only on understanding the processes that underpin these risk behaviors that I was mentioning, but also clinical interventions, evidence-based strategies that can allow us to promote behavior change and to surmount these problems. So with that, I think we have one housekeeping matter I wanted to bring to your attention. That is, there are continuing medical education credits available, but there's also a disclaimer here that you see, and I won't bother reading, that's important as well. So from here, I am really happy. Each year we invite someone from the University of Vermont leadership to offer opening remarks and kick us off. And so I'm thrilled this year that we have Kirk Dombrowski, who is the Vice President for Research at the University of Vermont, who's going to do that. But what's really special about this year and having Kirk do this is he's also an expert in addiction, being a pioneer in the area of addiction and the spread of infectious disease. He's trained as an anthropologist, having done training at Columbia University in the University of New York, and he spent a number of years doing research after he got his training there at the City University of New York, and led a really outstanding study on the spread of infectious disease among intravenous drug users in Puerto Rico. And after a number of years of his outstanding work in that area, he was recruited to the University of Nebraska in Lincoln, Nebraska, to set up a similar research operation there. And it led to him directing a center on rural addiction. And so it's so related to why we're here today, that you would go from being in New York City and focusing on Puerto Rico to the heartland and studying the spread of infectious disease and intravenous drug use in Nebraska. So we're very fortunate that Kirk is a New Englander and was lured back to the University of Vermont and is our vice president for research. So Kirk, please take it from here.
Thank you, Steve. You can hear me, right, Steve? I always wind up on
Yes.
mute when I don't
Yes,
know.
I can.
Great. Okay. Well, thanks. I think, yeah, thank you for having me. It's really a tremendous pleasure to be here. And I think the one piece that Steve left out was that he and I first met 5 years ago when I was pulling together a COBRI application, and Steve was actually one of my red team reviewers, and he came out to Nebraska and tried to set us on the right path, and eventually we were successful there, and he became the chair of our external advisory board. So one of the parts of the story he's leaving out is that he was actually my mentor in all of these efforts that we're doing in Nebraska, and since coming to Vermont, he remains my mentor on things Vermont. So it was really a pleasure to be invited to come and help kick off this meeting, and I'm really excited to actually be part of it. And I'll be in one of the sessions later talking a little bit about some of that Puerto Rico work and some of the network science that we've done. I wanted to just take 1 second, but as we start, to just acknowledge the NIH IDEA program, which has funded the VCBH. It's one of 5 COBRIs at UVM, 2 of which now have fully graduated through all 3 phases. We have 3 COBRIs right now, 2 in phase 1. 1 in phase 2, this one, VCBH. What a tremendous impact these centers have had. We also have a regional CTR that we share across northern New England that faces many of the similar kinds of issues that we do. We have an ITREP, a sort of the startup engine of the IDEA program, as well as an INBRI grant that that was just renewed. I believe if Rex is here, he can make sure I'm right, that it was our 4th renewal of our INBRI program. And this has just had a tremendous impact on the university and on the state. We're a small state, and we have been a small university, but we're a regional leader in NIH-funded research across the flagship universities of the region. And that's in large part due to consistent efforts across the INBRI program and work of some amazing center directors like Steve and others who have really taken the opportunity that the IDEA program presented and used it to build a university, and a university that serves a state and a region by building this huge research and medical intervention capacity. So I couldn't be more proud of that, and it's a really fun place to be a vice president for research, because we have all of these programs just charging along and raising the profile of the university. This year, we were up 25% on external awards. We're up 75% on external funding over the last 3 years. And this is driven by just these sorts of programs. So really exciting from a VPR standpoint to be part of all of that. The VCBH has really built an amazing foundation. Steve mentioned it, the sort of what he didn't talk about, and I'm sure you're going to hear more about, is some of these programs that have sort of budded off of this program, like the new Rural Addiction Center, are actually these enormous impact projects. And this is exactly what we hope for in a COBRI, is that we have a center, and the sort of things that that bud off of this center are just as impactful, just as dynamic. And it's really exciting to see the junior researchers establishing really robust research programs, spinning out into large labs, new centers, and so on. So it's a real credit to Steve's leadership and his ability to gather and hold talent at Vermont that we're able to be successful there. I don't have to tell this community about the importance of research on behavioral health. We now live in a single market economy that has wed together the economies of the entire globe. And at the center of that market economy is an ethos of choice, that what we do as humans and what we can achieve in this world is largely determined by all of these free choices we make in a market. And those markets erase social context, they erase entanglements, they erase the settings in which they're situated, and they erase the social obligations that are impacted by all those quote unquote free choices. And I say that coming from a background as an addiction researcher who looked at rural addiction, a context that makes very clear that choice is really embedded in deep social and biological factors, and that these sort of at market factors that erase the context of choice are really removing from people's vision a sense in which all of these behaviors are embedded in many, many chains of entanglement. So a critical feature of the VCBH, and I think what you'll see throughout this conference, is the breadth of approaches it brings together that try and put back in place all of those entanglements. If you listen to the media and you listen to this sort of neoliberal ethos of markets will solve everything, you lose touch with the fact that all of our behaviors, all of these decisions, all of these kinds of topics that consistently come back to be told, we're told are about freedom, are really very much embedded in factors that are specific to local areas and specific to individual families, communities, and so on. So I'm really excited when I looked at the program today to just see how much that breadth is reflected in what we're looking at. Biological factors, social factors, intermixed biosocial factors that are really trying to contextualize behavioral health in a much broader context than it is anywhere else in our media or in our world today. So really essential feature of research, correcting the kinds of ideological slippage that allows these serious problems to seem unexplainable on the outside. So with that in mind, I want to thank everyone ahead of time for really the work that goes into putting a conference like this together, and to the speakers and the work that stands behind the research that we're going to hear today and tomorrow. And really just to say, I'm excited about being here, both as a participant and on behalf of the university. I'm just really excited that we have these programs for this conference and the centers like we have under Steve's leadership. So welcome and thank you.
All right, thank you very much, Kirk, for those very kind and generous words. And so now, a special feature of the conference is we're going to have some remarks from Senator Leahy. So. I'm not getting his audio.
Hi, I'm Patrick Leahy, and I want to welcome you to the 8th Annual Conference on Behavior Change, Health, and Health Disparities, being sponsored by the Vermont Center on Behavior and Health. I've greeted you before at the start of your 2-day conference. I'm honored to do it again, but I must admit it feels strange to be sitting here in my office in the U.S. Capitol and not to be there with you personally. But I thank the University of Vermont for inviting me to recognize your dedication to the field of public health promotion. And like the University of Vermont, I'm proud of you. The Vermont Center on Behavior and Health plays an important role when you raise the awareness of major health epidemics in our state of Vermont. but you do it across the country. And now more than ever, addressing our public health needs. I don't have to tell you that requires leadership. It requires bold action. But it also requires our research community to come together and help us on this. So I thank you for your focus and diligence. My favorite nurse, my wife of all these decades, Marcel, she thanks you too. Over the past decade, the delivery of rural healthcare has been devastating. We've seen the closure of rural hospitals across the country and in our own state. Now, rural health centers have emerged at the forefront of our community's fight against the coronavirus pandemic. We saw the nation grapple how best to handle this pandemic, but the rural health centers kept their doors open. They worked very much to improve their telehealth capabilities, sometimes under all kinds of difficulty. But they played a pivotal role in coronavirus testing for many rural American communities, both in Vermont and around the country. Treatment centers had to temporarily close, support groups went virtual. And Americans suffering from a substance use disorder, they went into isolation. They had no one to turn to in this difficult time. And it's an unfortunate reality. The underserved regions face greater challenges to gain the resources they need to survive. We all know that. And that's why, as the vice chairman of the Senate Appropriations Committee, I made it a priority to fund the fight against the opioid mental health crisis that have ravaged our local communities, both large and small. It's through this work we established the Vermont Center on Rural Addiction at the University of Vermont. And that's been such a help. It's identifying, it's sharing approaches that have been proven to combat rural addiction. We saw Vermont's successful hub and spoke model, the community reinforcement approach, and that's why states around the country look at us in Vermont and ask, how did you do it? We want to do the same. I think of the groundbreaking research on rural addiction that's going to take place in the center. Now, I wish I could wave a magic wand and say, here, this is how addiction will be remedied overnight. But those of you who understand it far better than I know that can't be done. But with your help, we can continue to build solutions that are going to advance the health and well-being of families, not only in our state, but across the country, even in this new COVID era. And let us hope that someday it will be a post-COVID era, but we'll still keep working. Your efforts have truly made, they're going to continue to make a difference. And we'll work together. We'll overcome rural addiction. We'll continue to improve the delivery of rural health care. So thank you. I'm proud of you. I'm very proud of you. And both Marcel and I wish you all the best for a successful conference. Thank you very much.
Right, and thank you, Senator, for your support and for your leadership. It's important and we really appreciate it. Okay, so now I have the honor of introducing our keynote speaker, Stephen Woolf. I've followed Steve's work for a number of years and have been looking for an opportunity to get him involved in one of our conferences, and we just have not been able in the past to line up our schedules, but this time we succeeded, and I think our center is going to benefit greatly, and this conference will, for us having done so. So Steve is professor of family medicine and population health at Virginia Commonwealth University, where he is director emeritus and senior advisor at the VCU Center on Society and Health. And Steve has outstanding academic pedigree, as you might expect. He did a master's degree at Johns Hopkins, his medical degree at Emory University, then back to Johns Hopkins for a residency in preventive medicine and public health. He is board certified in both medicine and preventive medicine and public health, family medicine, preventive medicine, and public health. Has just had an outstanding research career, you know, the hundreds of publications in really high impact journals, JAMA Internal Medicine, the British Medical Journal. And I think one honor that really, for me at least, underscores what his peers think about him is that he was elected to the Institute of Medicine, the National Academy of Sciences, way back in 2001. So that's a statement unto itself about his academic and scholarly excellence. But if there was one paper that I want to recommend that if you haven't read it, that please do. And it's a 2019 paper in JAMA co-authored with Heidi Schoolmaker entitled Life Expectancy and Mortality Rates in the US 1959 to 2017. And I'm tempted, but I'm not going to do it, to go into details of why I think it's such a great paper, but I'm going to leave that to Steve because it's right, cuts right to the heart of this topic of rural addiction and health, and in particular, its impact on mortality. So Steve, thank you for taking time to be with us today, and look forward to hearing your presentation.
Well, thank you, Steve. It's a pleasure to be able to join you at the conference. I do wish we were able to meet in person as in the before times, but we'll have to make the best of the current circumstances. I'm actually going to be talking about the subject that Steve was just mentioning, which was work that we published last Thanksgiving, not knowing about the pandemic coming our way. So I'll pretend that we're back in time then and talk to you about the perspective we had at the time, but rest assured we're going to circle back to talk about COVID and how it connects in with all of this. So no disclosures to report. So if you've been following the news for the past few years, you're aware that there's been news coverage about life expectancy declining in the United States for several years. The media felt like this was a new development, but people in our field who have been looking at population health trends for many years were aware that this is actually a long-term process that began much earlier. What I'm showing you now is a slide that plots life expectancy back to the beginning of my life. So I was born in 1958. So what you can see here, the green line represents the average for the OECD. That's the Organization for Economic Cooperation and Development. The member countries of the OECD's average life expectancy is plotted on the green line, and the brown line represents the US life expectancy. So what you can see is when I was young, the US had higher life expectancy than peer countries. Then around 1998, the lines crossed, and US life expectancy fell below the US average. If you zoom in more closely, so now we're just looking at the portion from 1995 to 2016, you can see that the rate of advance of the other countries exceeded the pace of advances in the US. Then we plateaued, and then the drop that got the media attention occurred. But mind you, although there was some stabilization in the peer countries, the gap between the US and its peers widened. Now, in January of this year, we got some good news. There was a report from the CDC, the National Center for Health Statistics, that there had been a slight increase in life expectancy from 78.6 to 78.7 years. That was greeted with enthusiasm that this might be the end of that alarming decline. Most of us who were being interviewed by reporters at the time said that we don't want to jump to conclusions because that's a pretty small change. And of course had no idea that coronavirus had entered the country and that something big was about to happen to US life expectancy. I'll come back to that at the end. But let's talk about that long-term trend, because I think that history is really important context for understanding where we are now. You've seen slides like this before, where we contrast the health of Americans with the amount of money we spend on healthcare. So this happens to be from the Washington Post, and you can see the information I was just showing you on the left, the US life expectancy relative to the OECD, and on the right, US spending on healthcare relative to the OECD. So the tragic irony here is that we spend huge amounts of money on healthcare, but die earlier and are sicker than the people in the other countries. Back in 2013, I had the opportunity to chair a committee at the National Academy of Sciences that was charged by the NIH with looking into the reasons for this health disadvantage. And our report summed up the findings: shorter lives, poorer health. We documented a really substantial and wide-ranging problem in the United States in which the health of Americans was much poorer than people in other countries. I'll share with you some of the data. This table, by the way, if we were together in an auditorium, you'd have real trouble in the back of the room reading this. And you may still have trouble on your computer screen, but you really don't need to read the fine print here to get the basic point. This is a table showing mortality rates for the United States compared with the other peer countries that I'll be talking about. And basically all of these causes of death are causes of death where the US mortality rates exceed the average for the peer countries, whereas the smaller number of causes of death down at the bottom here are the ones where our mortality rate is equivalent or perhaps below the peer countries. And what you can immediately take away from this table is that this list is way longer than the one at the bottom, meaning that for most causes of death, the US is in trouble. And if you're a clinician and look closely at these causes of death, you'll see that we're talking about very different pathophysiologic processes, very different diseases, and behavioral health figures in there. You can see mental and behavioral disorders, suicide, drug overdoses. We'll come back to that later. But the diversity of these causes of death is so broad that it became clear to our panel that something more complicated was going on than just saying, well, Americans have higher mortality because of obesity or because of guns or some other distinguishing factor about the United States. This is a pretty chilling slide that we had in our report. It shows the probability of surviving to age 50 in the US versus other countries going back to the 1980s. So to orient you to this slide, the red dots are the United States, the gray dots are the peer countries. And so you can see in 1980 for men on the left side of the slide that we started out in the lower end of the range, and then as time went on, the US fell to the bottom of the ranking. But look here at females, also started at the bottom of the range, but look how over time it completely leaves the other countries behind. In other words, the probability of a woman surviving at age 50 is way lower if it's an American woman than if they live in any of the other countries. Again, the contrast in healthcare spending, the outlier here, of course, is the US. These are the other countries that spend less per capita on healthcare and live longer. So, I mean, the basic takeaway here for any graduate student or medical student should be that health is about more than healthcare, that we can spend lavishly on healthcare, but not necessarily improve health outcomes. Now, this is the study that Steve referred to that we published in November of last year, where we looked at life expectancy going back to 1959, not only for our country, but also for the 50 individual states. If you're interested in methodology, here's the method slide that tells you what we did. But basically, we were taking the vital statistics that are produced by the states and the Centers for Disease Control and analyzed them and sliced and diced them across demographic groups, geographic groups, and calculated how those life expectancy values changed over time. And what we found was that this phenomenon of decreasing US life expectancy is really being driven by health trends in what we call midlife. And I don't mean middle age here. I'm talking about the working age between 25 and 64 years. And we focused on that because when we looked at mortality for younger people, infants, children, teens, generally that was going in the direction we'd like over the years. Mortality has been declining like we'd like it to. And in older Americans, mortality in general for older adults has been going in the correct direction, lowering itself over time. But when you look at this age group, you see something very troubling. You see progress over a period of years in the beginning of this century, but then a turnaround around 2010 in which it basically does a 180 and midlife mortality starts climbing. And this hides a trend that actually began earlier. This is when all-cause mortality began climbing, but specific causes of death began climbing in the 1990s. What you have is sort of a tension between causes of death that are making progress and helping to lower our mortality. So examples would be progress in treating ischemic heart disease, reducing the rate of deaths from car accidents, better treatment for HIV/AIDS, better cancer therapies. All of these have a downward effect on our all-cause mortality. But then you have other causes of death that we'll talk about, like drug overdoses and other causes that were increasing. And the two were sort of in battle with each other, and the positive forces were winning out. But over time, the causes of death that were driving up mortality tipped the scales. And so it was at 2010 that those scales tipped and we saw an increase in all-cause mortality. But something ominous was underway way back in the 1990s. Now, if we break this out by race, which is always important to do, you see the big disparities that we know about, but are always worth refreshing our memory about. So the bold line represents the average for the US population over the period from 1990 to 2017. But you can see, for example, how this is the death rate for African Americans. And the first thing to jump out, of course, is the much higher mortality rate that African Americans have relative to other racial groups in the United States. This is this huge health inequality that we've been focusing on for so many years. And actually some progress in lowering that mortality and reducing the gap between mortality among African Americans and mortality among whites, which is represented by this light blue line. However, you can see that here's the increase in mortality among whites at this time. You can see that although African American mortality lowered, it too started increasing over time. Mortality in the Hispanic population, which is lower than for whites for reasons we can talk about during the Q&A, also began to increase. Basically, what we found was that although the media coverage originally reported this as a phenomenon affecting middle-aged whites, it was affecting all racial and ethnic groups. And it was not just middle-aged. This problem was starting among young adults as well. So what's behind this? Well, if you look at different age groups, you realize that there are different causes of death that are behind it. Again, these are going to be graphs that are going to require you to have a magnifying glass to read, but look closely at your screen and you can make out that this is the 25 to 34 year age group. And what's plotted here are the different causes of death that are contributing to it. You can see one that stands out very dramatically. That's drug poisoning. It's a cause of death that clearly is a factor in all of these age deciles that are shown here, the 25 to 34 year olds, people more middle age. But if you get up to folks who are in their 50s and 60s, you start to see that there was not only an increase in drug overdoses and other so-called deaths of despair, a term we'll talk about a bit more in the next few minutes, that refers to deaths from not only drugs, but also alcohol and suicides, but also deaths from chronic diseases like hypertensive heart disease, pulmonary disease, and other diabetes, obesity, organic diseases that are chronic in nature were also becoming more fatal in this age group. Don't worry about this too much, it's just a heat map, but the point of it is to show you that across many causes of death, 35 or so that we documented, these red boxes are increases in mortality. And you can see in general that there's this concentration of increasing mortality in this middle age group, not so much in young people, not so much in the elderly. Now, as I mentioned, we looked at this across all 50 states. So what you can see is that the percent increase, so this is the relative increase, was higher in certain states than others. I'll point out Vermont with my cursor here. So Vermont, like your neighbor New Hampshire and Maine, smaller populations in some of the other states on this graph, but large proportional increases in mortality between just 2010 and 2017 compared to other states across the country. If we look at a map and plot out the relative increase, you can see yourselves there. And you know, relative increases is one way of looking at it. Another way of looking at it is the actual absolute death rate. So this is a map where we take population size into account. And you'll notice that the New England area doesn't light up as prominently as it did in the previous slide. And that's because what we're looking at here is of all the excess deaths that occurred in the country because of this increase in mortality. So you sum up how many more Americans died during these years who would not have had mortality rates been stable. The states with larger populations are where more of those excess deaths are going to add up and accumulate. And what we see is that the concentration of it is in the industrial Midwest. In fact, what we found was in 4 Ohio Valley states, Ohio, Pennsylvania, Indiana, and Kentucky, we found 33% of all excess deaths. So let's put it in plain English, of all the excess deaths that occurred between 2010 and 2017 because of this trend, 1 out of 3 of them were occurring in these 4 states. So that tells us something. What's going on in terms of understanding what's behind this problem, understanding what's going on in a place like the Ohio Valley states is useful in trying to understand and unpack why the rates are going up there. Appalachia in general accounted for almost half of all excess deaths in the country. Now, the other thing that was very interesting, not only because we broke this out by states, but because we looked at this going all the way back to 1959, is we could see sort of the long-term health trajectory that states traveled through, their journey. And so, you know, New York right now has a reputation for having the 3rd highest life expectancy in the United States. And so for much of my career, I've thought of it as a pretty healthy place. But if you look back in time, you can see it wasn't always true. As recently as 1990, Oklahoma had a higher life expectancy than New York. But at that point, you see a parting of the ways, and New York's life expectancy starts climbing, and Oklahoma's doesn't really have much of a change. This is emblematic of a trend we see across many states, that something happened in the 1990s that started to create a divergence between the health of Americans, depending on what state they were in. It didn't used to matter as much. The health of Americans tended to be about the same from state to state. But beginning in the 90s, we started to see this stratification where your health depended quite a bit on what state you lived in. Think about COVID for a moment. We'll come back to that. But can you think of a current example of where your health is affected by the state that you live in? Just a thought experiment there. So you can see this post-1990 divergence. And, you know, comparing New York and Oklahoma is a bit unfair. There are different parts of the country. But even if we take adjacent states, so like this example, Colorado and Kansas, you can see a divergence that occurs. Alabama and Georgia, again, 1990, pretty much the same life expectancy. By recent years, quite a bit of difference between the life expectancy. This is, I can give you more examples, but you get the point. In the 1990s, there tended to be a parting of the ways. Now, I mentioned the comment earlier about medical students learning that health is about more than healthcare. This is actually a diagram from that report I showed you that we published in 2013 about the US health disadvantage. And one of our charges from NIH was not only to document how bad this health disadvantage is, but also to start thinking about what's responsible for it. Why is it that our health is so bad across so many different conditions? And a good way to get started with that task, at least for our committee, was to think about, well, what drives health? And then knowing that, we can then dig into the details and see where the source of the problem is. So this is a conceptual framework where you see health over on the right. So different metrics that you'd use for health, mortality, morbidity, life expectancy, what have you. healthcare is in this box. So it's important, obviously, it's necessary, but we would say it's necessary but not sufficient. Studies show that it accounts for about 10 to 20% of health outcomes. Our behaviors are hugely important, and we've been known about this for some time. Smoking, diet, physical activity, but also whether you use drugs, other behaviors, sexual practices are all very important to our health. But what we've come to understand as our understanding of public health has improved is that our living conditions affect both our access to healthcare and our behaviors. So this refers to things like education, income, housing, transportation, and the physical environment includes not only the physical environment, air pollution, or the built environment as to whether we have green space in our neighborhoods and parks and playgrounds and sidewalks, but also the social environment. Are we dealing with racial segregation? Are we dealing with systemic racism? Is there trauma, domestic violence, social isolation, loneliness? All of these are also important contributors to our health. And then at the macro level, public policies affect all of these. All of these boxes are affected by public policies. So to take a comprehensive approach to understanding why our health is different in the United States than from other countries, or why the health in New York is different than Oklahoma, the answer lies somewhere inside these boxes. So what explains this turnaround in midlife mortality? Why is it that death rates in this 25 to 64 age group are on the rise? Well, and this is why this is important to discuss at your conference, a big factor is substance abuse and behavioral health generally. Drugs in particular, the opioid epidemic specifically, have had a huge contribution to this increase in mortality. It's very striking. It's a huge chunk of it, but it would be a mistake to think that this is entirely explained by opioids or drugs. We see an increase in death from alcohol-related causes. We also see increases in death rates from tobacco and obesity-related conditions. So our behaviors are one potential explanation for this trend, but we also have to think about other possibilities, such as deficiencies in our healthcare system. That's important because you remember that table I showed you with the dozens and dozens of causes of death that involve different body systems and different pathophysiologic processes. None of these initial bullets, drugs, alcohol, smoking, could explain all of those. It's such a long list and it's so diverse that you have to start thinking about systemic factors, something about the way we live in America that is causing increases in mortality for so many conditions. And one obvious explanation might be our healthcare system. So the fact that we don't have universal healthcare, and even for folks who have health insurance, there's a large amount of co-payments and deductibles that make healthcare unaffordable. There's a fragmentation of our healthcare system, lack of coordination. Studies comparing our healthcare system to other countries show us not performing as well in terms of the quality of care, never mind the problems with access to care. But even that's not adequate. Healthcare alone can't explain this increase in mortality. So people have been thinking about such factors as psychological distress. This is where the death of despair notion comes in. Is there something about what's going on in our country that's causing a kind of social or emotional pain that is driving people to turn to coping behaviors that are unhealthy, drugs and alcohol being one of them, depression worsening, depression thereby explaining the increase in suicide rates? Is stress itself a causal factor? We know that the biology of stress and that the body in many different ways can be harmed by chronic exposure to stress. And to what extent is what we're seeing about socioeconomic conditions? And it could be all of the above. But you remember that slide showing the Ohio Valley. And I was saying, well, what is it about those 4 states and that industrial Midwest that could help teach us what's driving this trend? Well, that's the Rust Belt. That's where beginning in the 80s or so, we started to see a collapse of the steel industry and the auto industry and the coal mining and these were jobs that not only sustained families and workers for generations, but the local communities. So it's interesting to start thinking about the interaction between our economic lives, our economic conditions that Americans are facing, and how that drives health trends. An example of that is shown in this study here, which looked at counties where auto plants had closed and its relationship with opioid overdoses. There's a growing body of literature like this. This is just one example where researchers, often from different disciplines working together, are beginning to connect the dots between what we read in one part of our newspaper about labor markets and manufacturing jobs, and what we read about in other sections of the paper about our health care costs and health outcomes. This is a slide showing the increase, this is just recently came out, this study, in the percentage of Americans who are reporting that, the Burfus question about how many days in the past 30 days would you say that your mental health was poor? I'm paraphrasing the question, it's written much better than that. But you can see that if you measured, well, what percentage of Americans said 30 out of the past 30 days have been like that, which is a pretty bad situation. You can see the numbers have been trending upwards for some years. Again, signaling that something's up there in terms of the well-being of the country. Again, the point here is that I went to medical school. I was not taught about market economics, but increasingly as I've gotten older, I've begun to appreciate that these kinds of factors do make a difference in terms of explaining our health outcomes. So looking at what's happening in our economy is relevant to our health. Okay, I promised you I would bring up COVID, and then I'm about to stop so we can have some Q&A. So that report about US life expectancy, I said we published last Thanksgiving. We were obviously clueless that a pandemic was coming. But when the news did come that a pandemic was starting and that our lives were going to be totally disrupted, given this background that I've shared with you about the work we've been doing for some years, it didn't take long for people in my line of work to predict what was about to happen. If you go back to that slide that I showed you about the factors that shape our health, social and economic conditions, our environment, income, housing, employment, it didn't take rocket science to predict that a pandemic that shut us down, that we go into a lockdown and people lose their jobs and their income plummets, and they have unstable housing and don't know how they're going to make ends meet, that's going to have an impact on health. And obviously, large loss of life from the virus itself would have an impact on our life expectancy. Naively, even for someone who chaired a committee about the US health disadvantage, naively, I thought, well, clearly this is going to have a bad impact on US life expectancy, but in terms of our comparison with other countries, it's probably going to wash out because all of the countries, it's a global pandemic, all of the countries are going to take a hit on this, and we're all going to see an adverse impact on our life expectancy. What I did not anticipate was how badly our country would handle the pandemic. Other countries were much more successful in bending the curve and controlling community spread. And the loss of life in those countries, both in absolute numbers, but also even in terms of the mortality rate per 100,000, has been smaller. So researchers are now beginning to model what actual impact this pandemic is going to have on our life expectancy. And it looks like it's going to have a much larger impact on US life expectancy than it will have on virtually any other country in the world. So that slide I showed you at the beginning about the long-term gap between the US and other countries' life expectancy is probably about to widen and widen a lot. So we already were at a disadvantage, probably going to be more of a disadvantage now. Now, in a conference focusing on behavioral health, I mean, we can talk about COVID in many different respects in terms of its effect on respiratory deaths and so forth, but both because of the effects of people who have been traumatized by the illness itself, either among themselves or their families, but also the tremendous stress on American families right now as they try to survive through the pandemic and its ripple effects. we worry a lot about behavioral health and how that's going to affect our population. The opioid epidemic didn't disappear when COVID arrived, and anecdotal reports, at least, and maybe you all have better data up in Vermont. Anecdotal data, at least, are showing an increase in admissions for drug overdoses. We're trying to dig through the data to document whether mortality is increasing. It's probably going to take a little while to get the data down to a granular level where we can get current statistics on overdose death rates. But it will surprise no one if when we finally get that data, it shows an increase in drug overdose mortality. In our area, we're seeing it. This is data from our state's health department. I suspect you're seeing it there as well. But basically, this is looking at ER admissions or ED visits for overdoses. And you can see in the bars on the right for each of the regions of the state and for the statewide data, a clear increase in admissions for overdoses in 2020 compared to prior years. And it wasn't great in the prior years, but it's even worse now. So this can be a little bit overwhelming for those of you who are clinicians. You did not go to medical school or nursing school to be a social worker. So many doctors are not equipped to deal with a lot of the social and economic issues that are driving this. But there's many ways in which it can be factored in. We can talk about that during the Q&A, but I'd like to wrap it up now so we have more time for that. It's hard enough sitting in an audience with a person who talks too long, but even worse on Zoom. So let me wrap up by saying just the main findings here, that this recent decline in U.S. life expectancy is not new. It's been going on for a long time, most of my life. It's being driven by a very ominous trend in working age Americans from age 25 to 64. The causes of death responsible for it include a lot of behavioral causes, but not only behavioral causes. Other chronic diseases and injuries are also increasing. It's located in particular parts of the country, not so much out west in California and Oregon and places like that, but concentrated in the industrial Midwest, Central Appalachia, and New England, Northern New England in particular. There's lots of potential behavioral excuses we can give for this, but also we have to think about systemic factors that may be really driving this sort of pervasive trend. Ultimately, we're going to need more research to ultimately figure out what's responsible for this, but it's urgent research because we're literally lives are hanging in the balance until we figure it out. So I'll stop there and open it up for discussion.
Very wonderful, Steve. Thank you for that outstanding presentation. So you can send questions to Steve through the Q&A button. So Steve, while we wait for the first question, I would love to hear your thoughts on this, but I was reflecting that you trained at Johns Hopkins in Baltimore, probably around the same time that I trained there in addictions. It was a great place to train in these areas, but for a reason. You know, I went there from doing my doctoral studies in Lawrence, Kansas. And I was just struck by the economic conditions when I arrived. But I didn't make the connection. At that time, I wasn't connecting heroin addiction with the drying up of the steel industry. But I look back, I don't think it was a coincidence that we got outstanding training in these areas in Baltimore for a reason.
Yeah, and for those of you who don't know, the community there, Hopkins is located in East Baltimore, which is an area that was ravaged by economic changes in the years preceding the time that Steve and I showed up, and the health conditions that that community was struggling with were very difficult. It's a city, most of our American cities have the same pattern where life expectancy varies by as much as 20 years if you compare one zip code or census tract with another. And when reporters ask me why such a big gap in life expectancy, it has a lot to do with those social and economic factors that I mentioned earlier, where living conditions are so starkly different and segregated in much of our cities.
So I see the first question come in, and it's from Sarah Heil, and you mentioned that doctors aren't social workers and aren't prepared to deal with the psychosocial issues that have such an impact on their patients' health. Is that something that you think should change in medical school and postgraduate training for physicians?
Absolutely. And over my career, I've seen more of that happen. I think there's been more attention to behavioral health in the curriculum of health professional students. Clearly, there needs to be more. I also think our models of care delivery need to progress so that there's more integration between the behavioral and traditional sides of medical care. Too often there's this terrible fragmentation where people are referred out and get lost in the system and don't have access to therapists, to family counselors, to substance abuse programs. And should they get into one of those programs, and there's lots of barriers to access, the crosstalk and communication between the behavioral health providers and their regular family physician or what have you are so terrible that you don't really have a seamless, streamlined approach. So people fall through the cracks, and that's on a good day. In a pandemic, it's just way worse.
I'm not seeing another question, so I'll take the opportunity to ask you one, Steve. When I saw that you did a residency in preventive medicine, I was very impressed. I was curious, do you have one at VCU, and what's involved in establishing a residency in preventive medicine?
We had one at VCU some years ago, but not now. They're typically located at schools of public health. Mm-hmm. Preventive medicine residencies are 2-year training programs that include the obtaining a master's degree in public health at MPH in the first year, and in the second year, practicum rotations that occur in different population public health settings. Mm-hmm. There are residency programs that prepare people for careers often in public health. So, or people can build off of their existing clinical training and add in, as I did, a second clinical specialty in preventive medicine and public health.
Right. I couldn't help but reflect, based on your data about Northern New England, that there may be a role for such a residency if we don't already have one. It's far outside of my area of expertise. So I see a couple questions here for you. One from Laura Nicole Coughlin. With regard to rural area where jobs have been dwindling over time, what ideas do you have for potential solutions to improve population health in these areas in particular?
Well, again, it's a great question and very relevant, because I know you're very focused on rural health issues, which are really gripping the entire country, but obviously they look different in New England than they might be in a ranching community in Wyoming or something. But for all these areas, there's a question of whether you look at it in terms of the proximal drivers or go upstream. So in terms of the proximal drivers, we talk about people in rural areas needing remote access to care, and other design solutions so that some of the immediate barriers that they have in getting care delivery are dealt with. And we can talk more about that, but I think the kinds of design solutions I'm talking about. What often doesn't get discussed, at least in medical and clinical conversations, are these macro influences like the economic conditions, access to wireless, where are the jobs going? And because I'm a believer that health is very much affected by socioeconomic conditions, the economic vice grip that's affecting so many rural communities is actually probably the most important thing we could focus on to improve health outcomes. So the question then becomes, how do we bring jobs that pay a livable wage to rural communities that have been devastated by the decline of industries that once sustained them. And the formation of large agribusinesses that have hurt family farmers. The fact that young people flee many rural counties to go get their education and don't come back. So you have this loss of population, leaving behind very often a less healthy population, and the folks who were not able to pursue an education. They flee because there aren't, once they get their education, there aren't jobs in their hometown that can support the kind of work they've trained to do. So changing that dynamic and bringing new industries and new job opportunities and educational opportunities to rural communities could really change these dynamics. But doing that requires people who don't wear stethoscopes to actually make some changes in labor market policies, investing in conditions that will attract industries, and making economic development of these neglected communities a priority.
Yeah. Excellent point. So here's a question that I'm all too familiar with, painfully. How long does it often take? So it's Denise Peters. How long does it often take from publication of health research data and insights to actual health policy change from a historical perspective? I laugh only because it's so painfully long, but Steve, you, I'm sure, have some things to say.
Yeah, I mean, there are exceptions that we could talk about, but the general lifespan or whatever we want to use for a term between new knowledge appearing in the medical literature and changes in practice is very long. There have been studies actually that have claimed it's as long as like 15 years before you really see big shifts in practice. Over the course of my career, I've seen that that's not always true. Sometimes we have groundbreaking pieces of evidence where there's immediate changes in practice, and you don't need to look much further than COVID itself to see that happening in real time now, that any new data that are coming out about remdesivir or other treatments for the disease is getting rushed out into publication, and clinicians are trying to grab whatever decent data they can get and offer that kind of care to their patients. Drugs that have immediately been pulled from the market because, and this is not just COVID, but in other fields as well, because of adverse effects that have been identified, that practice changes pretty fast. But those exceptions aside, unfortunately, we find that health professionals get stuck in their old ways and have a difficult time changing practice behaviors, even when new evidence becomes available. It has to reach a critical mass and tipping point before you finally start to see a change in practice.
Yeah. One in my own career is how long it's taken to disseminate the efficacy of medications for opioid use disorder. And so for communities have just resisted that evidence. And finally, as the epidemic has spread throughout the heartland, we see that that has come around and that people now are moving in that direction. But it has taken years, despite tremendous evidence saying that that's the direction we should go in. So here's another from Martha Whitfield. Do you feel that fee for service as opposed to capitated payment reimbursement models are contributing to the disconnect you described for patients who may get referred out for behavioral care?
Yes, absolutely. I think we have a perverse payment model. This is one of the reasons why we spend so much on healthcare in the United States compared to people in other countries. It's not only perverse in the sense that it incentivizes more procedures and treatments than probably should be done, but the value placed on what we pay for is backwards. So behavioral health, if you came from Mars and looked at the data, would say this is probably the most important thing we should be investing in. There should be huge amounts of money going toward that. And cosmetic surgery, probably not so much. So that's what the Martian would say. But our payment system is completely the opposite, right? So the interventions that, you know, researchers like myself would say would save the most lives are really disincentivized by our payment structure. Not to mention all the bureaucratic obstacles to getting it done. But yeah, I totally agree that that's a major contributor.
Mhm. So again, a pause, please. We have plenty of time for additional questions, but I'm going to keep taking advantage when there's a pause. So Steve, one that I'm familiar with and that we're wrestling with here in Vermont is, I think sometimes we get desensitized, those of us even in leadership in healthcare, to certain things we've been just surrounded by. And the one that I have in mind is cigarette smoking. So it's well established, it's killing 500,000 Americans every year, losing 10 or more years of life related to smoking. And yet in our hospitals and whatnot, we often just walk right by it. And I was just curious what your experience is with that and whether you have any recommendations around it.
It's another example of what we were just discussing. I mean, it is the leading cause of death in the United States. It has been for many years, and even with COVID, it'll still be the leading cause of death in the United States. Yeah. And I think a lot of progress has occurred during my career with tobacco control, because it wasn't enough to count on the healthcare professionals to fix the problem. We haven't done a good job of that. But also, actually, the research showed that even if we did a perfect job of doing that, it wasn't enough to change people's behavior because it's such an addictive agent. So the policies that changed the rules on indoor smoking and other tobacco bans, cigarette taxes, and other measures that were coupled with educational programs to raise awareness about smoking, actually started to change our culture. So you saw fewer movie stars smoking in films, and in airports and restaurants, our practices began to change around smoking. And those kinds of cultural and environmental changes, I think, have helped to reduce our smoking rates, which are much, much lower than they were back in the 1960s when the Luther Terry Surgeon General's report came out. However, if you dig into the data, you'll see huge disparities in smoking by social class and by race in this country. Although people with a college education, you've seen their smoking rates drop very nicely. People with less education, there's not been as much progress. And large percentages of patients with mental health issues are smoking. So there's this intersection between smoking and mental illness that has not been well addressed. So there's much more to do, and I think it remains a priority.
Yeah.
I see there's questions in the chat box. Should we be looking at those?
Yeah, go ahead, Steve. So if you see those, yeah.
Mike, I see this one. A lot of these are policy issues. Are politicians listening? Also, any thoughts on universal basic income affecting healthcare and quality of life, per Andrew Yang? So that's a couple of questions there, very good ones. They are policy issues, and they are the kinds of messages that you really need to bring to elected officials. In terms of answering whether they're listening, I have to differentiate between national, state, and local, because I think the story is a little different. The most positive is at the local level. So many communities, cities, county boards of supervisors, regional planning commissions are getting this and are thinking in creative ways about how to make investments to create as the Robert Wood Johnson Foundation calls it, a culture of health. There are many communities around the country, big and small, who've won awards for really creative policy making to take a holistic approach to improving health in their communities. Some states have done a better job. Again, as I mentioned, there's been a divergence. So there's some states that I think have had very unimpressive histories in terms of what they've done around health outcomes. but others that have been very forward-leaning in terms of adopting state policies. States are supposed to be laboratories for policy innovation, you know, when you study civics. And many states have had some great successes there. Federal government, you all know how that's going. Here we have a situation where that level of government is pretty much ineffective in doing much of anything, let alone change the way we approach health outcomes. And, you know, whereas just up until a few years ago, I was very active in testifying on Capitol Hill and other places in bringing data and charts and research to hearings and elected officials who were interested in putting that data to use and thinking about policy. We now currently are in a time where I feel that data and evidence and science are not very persuasive anymore. I keep hoping that that's going to change, but right now that doesn't seem to be the case. Yang's concept of universal basic income sits among a set of different ideas, some more conservative, some more progressive, but are all thinking about ways to help deal with the fact that median income in this country for all but the very rich has been stagnant since really the 1970s. Adjusted for inflation, we've not really helped people and families meet basic needs. So housing costs have gone up, healthcare costs have gone up, and yet the income levels have not gone up. So there are various ways of approaching this that we could debate politically, but the important point is some solutions need to occur in this area. The income inequality that has been widening so drastically since the 1970s is literally costing the lives of American people. So we're not only economically at a disadvantage because of it. Economists will tell you that income inequality is very bad for our economy, but it is literally claiming all these lives. And we're seeing this climb in mortality as a result.
Yeah. Great. Steve, I was wondering, we're almost out of time, but there's a little bit of time left. If you could speak to the differences in life expectancy in the Hispanic ethnicity group.
Yeah, so going back to that chart where you saw the lower mortality for Hispanic Americans than for whites, and that's something that has a name. It's called the Hispanic paradox, and it's in the literature if you look it up. For some years, this has been noticed. What it turns out to be, and other countries have seen this too, they call it an immigrant paradox. New immigrants to countries, industrialized countries, tend to have better health than the people that grew up there. And there are various theories for why that is. Among them, as you know, people coming from other countries come from countries with healthier lifestyles where they're more physically active, eat diets that are more plant-based and so forth. There's also other theories about acculturation and other factors. That rule though, that pattern is starting to fall apart now. So Hispanic Americans, for example, have much higher rates of diabetes and associated complications from obesity than white Americans. COVID right now is an example where the exposure to the virus and the mortality rates of the virus are much higher in Hispanic Americans than in white Americans. So the old Hispanic paradox is beginning, unfortunately, to fall apart. And we're starting to see the kinds of disparities in that community of color that we've seen for so many years among Native Americans and Blacks.
Okay, well, Steve, thank you for such a terrific talk and for sharing your knowledge with us. It's been tremendously. For example, the Hispanic paradox I did not know about. So that's just one simple example, but it's just been tremendous to have you here. So thank you. And I hope we get a chance to do this again.
My pleasure. Thank you for letting me join you, and good luck with the rest of the conference.
Thank you. So we have now approximately 15 minutes. We are going to start our first panel discussion at 10 o'clock sharp. Please be back by that time if at all possible. Thank you.